the Nigerian Society of Anesthetists for this very topical issue that we don't like to talk about. The second victim phenomenon, psychological first aid after adverse clinical events. So my topic is very simple. How do we navigate this problem? You've even made it easier for me by suggesting one option, psychological first aid. I have chosen this few learning objectives, and I hope I am able to accomplish this by the time we finish the discussion, as well as the question and answer session. Please don't let me leave until I have done justice to these objectives. My first objective is that at the end of this interaction, we should be able to identify the second victim phenomenon in ourselves or our colleagues. Two, we should know how to offer psychological first aid when colleagues are in distress. And this one, ambitious, I'm hoping I can accomplish this as well. There is very little research into the mental health of health workers. So I'm hoping I could stimulate research in resilience building programs for healthcare workers. As we talk about the second victim phenomenon, it might strike one or two chords, and we may be able to collaborate on what can we do to support colleagues who go through different forms of distress, including this second victim phenomenon we will discuss today. And to achieve those objectives, I have a very simple outline. So the rest assured, we would have no boring moment. I'll start with an introduction and a few definitions. Then we'll go straight to how do we navigate the second victim phenomenon if it happens to us. What are the basics of psychological first aid? And I'm hoping the Nigerian Society of Anesthetists will afford this bonus, slide on building resilience as a specialist. Now, that was on a lighter note. But I decided to add that bonus slide because part of my work as a consultation liaison psychiatrist is the healthcare, the mental health of healthcare workers. So in my work with colleagues and even other healthcare workers, I've noticed that there is a great need to build resilience in this stressful profession, especially in these days of JAPA, where we are getting fewer and fewer, and we're embracing more of Western civilization. The social media is more and more active. Patients are more aware of their rights. The terrain is not as easy as it used to be. Then there will be a conclusion slide. Adverse clinical events are not as rare as we may think they are. In Calabar, I recently heard of what could seem to be an adverse clinical event. The chairman of the education committee of NSA and the president-elect, maybe if she's inclined, she might talk more about that. I hear a patient died in theater. I was hearing from lay people on the streets. A patient who seems to be related to prominent people died, and people thought it was unexpected and thought the doctors may not have done what they were supposed to do. So it happens everywhere, every day, worldwide. And there are high-risk areas for adverse clinical events. The intensive care units, the operating rooms, and emergency units. These are well-known high-risk areas. And that's why surgical specialties, are more likely to encounter adverse clinical events more often. In fact, a recent WHO publication in 2020 estimated that in high-income countries, 1 in 10 patients suffer adverse clinical events. Now, you can imagine that in low-income countries, that number will be higher for a variety of reasons. In the year 2000, there was an Institute of Medicine report. Institute of Medicine is in the United States of America. The title of that report was "To Err is Human." It was really it was one of its kind, because the paternalistic approach to medicine, making us feel doctors are not humans. They don't make mistakes. We know it all. And these things happen and people don't like to talk about it. But this report really got us to start talking about it. And I think that's where the healing started from. But interestingly, that report showed that most of the causes of adverse clinical events are actually systemic. But in places like America, for instance, where everything, media sensationalization of things, it will be about the practitioner, about the doctor. People will start digging up his love life, where he goes to drink, where he attended primary school, and everything is smeared on the media. And, people enjoy this thing about somebody should take the blame. And unfortunately, the poor doctor suffers for it. So Albert Hu wrote an editorial in the British Medical Journal that year, that's in 2000, and said it's not only the patient that suffers. Yes, the patient is the first victim, but the doctor who made the mistake is the second victim, and he deserves help too. So that term, second victim, came into our consciousness. And since then, people began talking about it. And, this is where we are today. The third victim is being described nowadays is usually the organization, or, yes, usually the organization is referred to as the third victim. So let's take a few definitions so we can understand this concept a little more. An adverse clinical event can also be called a medical error. The Institute of Medicine definition, broad definition, is quite complex, and usually that should be for medical legal reasons. But I saw this definition that was easier for us to understand. It's a preventable adverse event that affects a patient by prolonging treatment or causing discomfort, disability, or death. So anything that is preventable, either by omission or commission, that prolongs treatment, causes discomfort, of course, significant discomfort, disability, or sometimes fatal. Usually we talk about the fatal ones, but there are other medical errors in quotes that could be classified under this. Now, there is a very useful classification in case people are interested in research. That's part of my objective, is to stimulate research. There's a WHO publication, the Conceptual Framework for the International Classification for Patient Safety. One can find a useful classification there. I'm not going to focus on adverse clinical events. It's not something we plan for. It's not something we want. Remember the way we are trained, that first, do no harm. So it's not something we plan for. It's not something we want. So I'm not going to talk about it much because it's not the focus of this lecture. But I think we should also take a detailed definition of who a second victim is. And Scott, if you're doing any research on second victim phenomenon, it would be nice to consult some of the work Scott has done with his team. A second victim is a healthcare provider involved in an unanticipated adverse patient event, medical error, and/or patient-related injury, who became victimized in the sense that the provider is traumatized by the event. Frequently, second victims feel personally responsible for the unexpected patient outcomes and feel as though they have failed their patient, second-guessing their clinical skills and knowledge base. So you imagine leaving your house in the morning, wearing your best, attire, looking very sharp, very confident of your skills. You get into your beautiful car, you drive to work, and you go into your work zone. In your case, you change to scrubs and you get into your work zone, and something happens that turns your whole world upside down. It can be very traumatic. But we must differentiate this from vicarious trauma. Vicarious trauma is acute stress disorder or post-traumatic stress disorder, or something resembling it, that results from people who work with trauma victims. So you work with trauma victims over a while because of all the empathy we're supposed to show in our care, vicarious trauma can come as a result. This is different from the second victim phenomenon. Now, psychological first aid. Psychological first aid is simply a humane, supportive response to a fellow human being who is suffering or in distress and who may need support. And this involves practical care and support, which does not intrude. Very important. Later on, we'll talk more about that when we discuss the basics of psychological first aid. Psychological first aid also involves assessing people's needs and concerns. It also involves helping people to address their basic needs, food, water, information, listening to them but not pressuring them to talk, comforting people and helping them to feel calm, helping people connect to information, services, and social supports, protecting people from further harm. That's, it is part of the definition of psychological first aid. Now, we move on to what psychological first aid is not. Psychological first aid is not only for people like me, psychiatrists, and clinical psychologists to deliver. Sorry. It's not professional counseling. I've seen people who said, in the process of my work, people will tell me, don't worry about that. I'm a counselor in my church. That's fine. That's fine. But the typical idea of counseling around here, even when people, secondary schools, is more of lecturing. You give advice. You tell people, and Nigerians, we advise a lot. It's not professional counseling. Later on, when we talk about the basics of psychological first aid, I'm hoping we will move from our de facto counseling style to this approach that is evidence-based, that can help people to negotiate this kind of difficult situation of the second victim phenomenon. It's not psychological debriefing. Some people in the past may have heard that debriefing is helpful after traumatic events. They do it in the military. You come out from a theater of warfare and you're debriefed. But debriefing does not work. The evidence has shown that debriefing may even be harmful after a traumatic incident. So it's not psychological debriefing. Eventually, when we're discussing the basics of psychological first aid, we'll discuss more why debriefing should not be done. It's also not an analysis of what happened. Trying to, out of our own curiosity, we are trying to put the time and event in order. That becomes an interrogation. It's not that. It's not pressuring people to talk about the event or their reaction or even judging them. That's not what psychological first aid is about. We will eventually get to talk about what it is. Now, to help us understand a little more about how to support people in distress, it might be helpful to do a little reading on Kubler-Ross stages of grief. It's been around since the last century, 1969. The stages of grief demonstrates how people process significant loss. And in this case, something happens at work, a prominent person, your whole world turns upside down. Before you know it, people are already putting you of that. That's sudden loss of your status, sudden loss of that beloved physician status or surgeon, doctor status you used to have. And, Kubler-Ross stages of grief can also explain system respond to stress after a traumatic incident. Similar to what we learned in pathology about the stages of the inflammatory response. Just like the physical body reacts to trauma, the emotional system, emotional part of the body also reacts to stress. And there's an acute phase, there's a reaction phase, there's a repair phase, there's a reorientation phase. And I put the estimated time this takes, though it can be different for different people. Now, what's the point of this slide? The point of this slide is it takes time for people to respond to things, and we are all different. Psychological first aid simply is the support you give the body, you give the person, you give your colleague to heal. Because the central dogma of biology is homeostasis. When a system is challenged, the body tries to come together. The body will heal. But there are things we can do, or there are things about the person that may prevent this healing process. And psychological first aid is simply supporting the person to heal, to get to the outcome that we desire. So how does one navigate this kind of difficult situation? The situation no doctor wants to be in. The situation no anesthetist wants to be in. The second victim phenomenon. Keep in mind that not everybody will develop it. Just because somebody has been involved in an adverse clinical event or even has to face a disciplinary panel or an investigation panel does not mean you already have second victim phenomenon. Let's not abuse it. With time, governments and authorities may recognize that this is something that happens to healthcare workers in such situations. If it is abused or people just use it to prevent, maybe an inquisition or an investigation into the process, then we may not, those who really have it, may not have the support that they deserve from the system. Not everyone will develop it. And let's not underestimate the kind of training we received even from medical school. Doctors who get into the military for short service, they usually do better on a lot of parameters in military school, even compared to those who started that officers academy, Nigerian Defense Academy from first year, just 6 months in the training, because of the kind of training we have received. And that training is meant to help us deal with difficult situations. So not all will develop it. However, it is important to be aware that the second victim phenomenon exists and that we are human. We are not superhuman. Because the other mistake we might make is we get overconfident. No, I've gone through worse times. And we refuse to recognize that something is decompensating within us. And we refuse to recognize that this one is different. And certain personality types are overrepresented in medicine and in some specialties. Like anesthesiology, there may be some people, certain personality types that you might find if you do personality testing among anesthetists, a survey, you might find that certain personality types are overrepresented there. So knowing that our personality type can predispose us to this may also help us. It's also important to be honest. Sometimes we make the mistake of hiding the truth. Of course, it's not everybody who will tell things as they are too. It can be used against you. But we must say it as it is to certain people. It might be our HOD. It might be our mentor, someone we can trust that will understand, okay, this is what happened, and might be able to protect us. So honesty is very important because it lifts a burden off you. Already, your conscience, your mind is troubling you. This is what I did. I didn't mean to do it, but it happened. It might have been overwork. It might have been something else, but it happened. Carrying this burden within us, refusing to be honest about it, even when people are trying to gather evidence here and there and confronting us with it, may make the matter more difficult. Now, usually when things happen, we have emotion-focused coping and we have problem-focused coping. In emotion-focused coping, we react emotionally to the situation. We get angry, we get sad, we get worked up, but eventually we find ourselves calming down and looking at the situation. What do I do next? That is the normal way we react to situations. So in this kind of traumatic situation, people can be stuck in emotion-focused coping. For instance, the person seems to have recovered from that process, but it tells you, when I see a patient like this, a patient like this, a patient like this, I will look for an excuse to cancel that surgery. I don't take such patients. So that's called emotional distancing. The person has associated certain types of patients with problem. That is, the person is stuck in emotion-focused coping. So do not spend too much time on emotion-focused coping. Look at coping. You will see emotion-focused coping, problem-focused coping. There comes a time when you will look at that adverse clinical event. What could I have done differently? What could have contributed to this from my own side? And you analyze the whole situation. What is the way out right now? What do I do? How do I recover from this? You are now getting into problem-focused coping. Introspection is good, but do not isolate yourself. The tendency can be, oh, I'm not a good physician. Oh, my whole world is falling apart. I'm not going to succeed. People are laughing at me. That temptation might be there to isolate yourself, but please don't do it. Maintain regular communication, especially with your mentors and your peers. Don't stay away from the MD Khan lounge because of what has happened. Go there once in a while. But please do not grant media interviews or post things even on your WhatsApp status or on social media without guidance. In fact, at such times, it's best to stay off social media because emotionally we may not be very balanced. And we might see things in social media that may worsen our distress. And please get a lawyer because the hospital lawyer, his job is to protect management, not you. Please get a lawyer. It might be necessary in some cases, after adverse clinical events. And get a lawyer you trust. It might help you navigate the second victim phenomenon. Now, Scott, like I mentioned earlier, is one who has done a lot of research on this second victim phenomenon. He developed a recovery trajectory based on evidence, based on research, generally how people recover from such things, because recovery is the norm. Recovery happens, but some people may not recover. Some people may be stuck at one of these stages. The first stage is chaos and accident response. The adrenaline system goes haywire, the autonomic nervous system, cortisol levels are very high, issues with sleep. Then there comes a stage of intrusive reflection where you ask yourself a lot of questions. What ifs? What's that? That day I shouldn't have worn a yellow shirt, or I shouldn't have worn my blue scrubs. Things like that. Then the third stage is restoring personal dignity, personal integrity. The fourth stage is the stage of being able to endure the inquisition. And stage 5 is obtaining emotional first aid. I don't know if he meant psychological first aid there, but research has shown now that psychological first aid should start from day one. From day one, it might help people negotiate all these stages. And the last stage, stage 6, is either the person moves on in that same environment or drops out, either changes profession or changes location. That may be another push factor for, migration. The other part of stage 6 is either the person is just surviving or the person thrives. What doesn't kill you can make you stronger. And thriving is what we call in mental health resilience. So now let's talk about psychological first aid. Please do not administer psychological first aid for someone in such a situation you're not friendly with. It's better the person is your friend. Be willing to help. Don't just do it because you have to. Do it because you want to. Be willing. Because you need to be there for the person. Remember, the psychological response to a traumatic event takes time. Who knows if this is one of the reasons the suicide rates are quite high among anesthetists. Of course, psychiatrists too. also have high suicide risks. But who knows if the second victim phenomenon might be responsible for this? So be willing to give psychological first aid. At least one or two people in the department. What the person needs more at that time is company. Company, be there for him. You may offer to drive. The person may be acting tough and everything, but be there for him. Visit more often. Spend time with the person. Sometimes it might just be silences. Be comfortable with that silence. Don't pressure the person to talk. Remember, after a traumatic incident, what is done in debriefing is people talk. But when people talk about things they are not ready to talk about, it causes more harm. That is what the research has shown. So even when he's not ready to talk, just keep him company. If he talks, listen more. Don't be quick to judge or give advice. Your calmness is infectious. Try to be calm. Try to keep a calm demeanor. Show him that this too shall pass. Because it will pass. And it's very important to maintain strict confidentiality. Unless you have to tell things to people who need to know. For instance, the person expresses strong suicidal thoughts. Then we need to tell someone. We need to get help for the person. Now, the operating guidelines of psychological first aid are the 3 L's. The 3 L's. Look, listen, and link. I've sent the psychological first aid manual, though it's prepared for field workers in crisis areas, but it can also be adapted for use for us. So I've sent it to the moderator, who I'm sure will be able to share it with other members of the Nigerian Society of Anesthetists. But I'm going to explain look, listen, and link. So look. Remember, there's very little here about talking, about giving advice. So you look, you observe. Non-verbal communication is strong. And it's better when that person is your friend. Without saying much, you can observe. You can feel to an extent what the person is going through. So look, observe. The person's house. Are there things that may cause harm or worsen the problem? Is the person beginning to use psychoactive substance more, even if it's just alcohol? Because psychoactive substance will worsen the problem. So that's part of looking. Observe. Observe to limit harm. Observe the person's needs. Sometimes you notice something the person needs, the next day you come back with it. He's telling the person something. I am not a failure. Everybody has not abandoned me. I made a mistake. I didn't mean it. I still have people who stand by me. So look out for the person's needs. Look for any danger. Look at where you need to give the person information. And listen. Listen. Now, in mental health, for some of us who have psychotherapy training, we are trained to listen. And there are different types of listening. For instance, reflective listening is not easy to teach in a place like this. But let's talk about listening with empathy, active listening. Let the person know you are listening. Sometimes the person is talking. Wow, sorry about that. You are adding some things to encourage the person to talk more. You're nodding your head. In fact, in psychological first aid, we say, listen with your eyes, with your ears, and with your heart. EEH. Listen with your eyes, with your ears, and with your heart. Let the person know you actually are interested in his feelings. It's more important than advice. It's more important than judgment. At that time, it's not your feelings that matter. It's not your thoughts that matter. Whatever has happened already. We are trying to support the person to heal, to come out of this, to come out of emotion-focused coming, to come to a place of emotional balance where he can begin to think of how we can get out of a situation. A time will come when the person will ask for your advice. But the earlier parts, look, listen, and link. Link is very important because there's no heroics here. Sometimes the person's situation can be more than what you can handle. Sometimes the person needs a professional, an expert, a psychiatrist. Sometimes the person needs to be linked up to the hospital, program for that. Some hospitals have programs for that. The person may not have the energy to do it. So the 3 points in the operational guidelines for psychological first aid, the 3 L's are look, listen, and lean. Of course, when we look at the manual, we can expand it and have our own pattern for psychological first aid. It's very important because imagine when, because of the second victim phenomenon, it ends in an outcome we don't like, suicide. Such a well-trained doctor, after basic medical training, another grueling residency training to become an anesthetist. There are very few in the country. And we are not able to offer the support the person needs to get out of this. It might be very sad. That's why it's important to master psychological first aid. Keep away all your feelings of jealousy. Keep away all your feelings of competition. Our goal at this point is to save our colleague, because this can happen to any of us. Now, the bonus slide, because as specialists, we're getting fewer and we're getting overworked. The world is changing. It's important to build resilience as a specialist. Things will not always be rosy. And residency doesn't really train us for this kind of things. Doesn't really train us much for resilience. If we're not careful, residency might actually make us more vulnerable to certain things, especially related to mental health. So one of the things I'm suggesting based on my work, because in my work, I deal with mental health of a variety of healthcare workers, including medical consultants. I tell you a small story. A CMD of one of the hospitals in the country, not in Calabar, one of the hospitals in the country, a certain time had a situation where a prominent politician died in his hospital as CMD, or was said to die. And he tried to cover the doctor who would have gone in for it. So he took responsibility for all that happened. So he became not just second victim, but also the third victim, because he was representing the organization. The organization suffered. He suffered as a person. And that CMD has not recovered from that problem. That was probably more than 20 years ago. What's the point? What we do right now before adverse clinical events happen can make a difference. How we will pull through such situations and thrive. That's the goal of resilience. So let's be deliberate about what we do about resilience, even as specialists, because the country needs us. So my first suggestion is check your defense mechanisms. Now, defense mechanisms can sometimes be used interchangeably with coping mechanisms. But really, defense mechanisms are unconscious. Analyze yourself. The last time I faced a difficult, unexpected situation, maybe on the road while driving to work, maybe while traveling with policemen, or somebody hits my car or something, how did I react? Maybe I have a challenge with a colleague, something that really made me angry, maybe a betrayal situation. How did I react? Now, go search for yourself the classification of defense mechanisms into immature and mature defense mechanisms. By the time you check that classification, you will be able to check yourself. Which defense mechanisms do I use more commonly without thinking? And you can now relearn. You can look at the mature coping mechanism. For instance, something as simple as humor. A difficult situation, you diffuse the tension with humor. And you are calm, all parties are calm. Can we begin to learn that as a defense, a coping mechanism? There are other mature coping mechanisms. Something bad has happened to you. You try to work to make sure that does not happen to another person. Sublimation. So you can relearn the mature defense mechanisms as your own coping mechanisms going forward. You're being deliberate about how you handle difficult situations instead of just giving in to yourself and saying, that's the way I am, take it or leave it. That way of coping may push you into the second victim phenomenon and get you stuck when you are involved in an adverse clinical event. And whatever you do, please, keep your social connections strong. Yes, you may have had difficulties in residency, maybe delayed more than you expected, more than your personal timeline. And now you're a consultant, you're a specialist. You have your financial goals. You have your academic goals. You have your career goals. I should be this in this time. And because of that, you may be running so fast that you don't have time for friendships. You don't go to the MD Khan lounge. You don't find time on weekends to visit your friends. You don't spend time with your spouse. You don't spend time with your children. These are vulnerabilities. You may need them when things go south, when things do not go the way you expect. And please, do not use substance. Sorry, use is not there. Do not use substance in difficult times. We can make it as a habit. Anytime I'm going through certain difficulties, I can avoid alcohol or whatever it is you may take to give you strength. If you don't feel like getting out of bed, please, just know that your body is telling you something. That stimulant you may need to take, even if it's coffee. Sometimes you may check is my use of coffee increasing? Is my use of alcohol increasing? Or this particular substance I use to energize me, is it increasing? And it might increase in emotionally difficult times. You may need to stay away at that time because it is in those moments that you draw inner strength. If substance is not in the picture, it is in those moments that you build resilience. And that's why we fear for this generation. As medical students, they know different chemical substances they use to overcome different situations. Sometimes we call them the chemical coping generation. Difficulties are supposed to help you adjust the way you deal with situations, are supposed to build you. But when you use chemicals, you remain immature emotionally. And a time might come when you might not have access to the chemical, or the chemical might no longer work. Tolerance is part of dependence to psychoactive substances. So do not use substance in difficult times. And please, whatever you do, have a mentor. Your first supervisor, the dynamics may not have been very what you would expect, or any of your supervisors. Or you may feel because residency was troublesome, nobody in your department likes you. And now you have your paper, you have your fellowship, to hell with everybody. I'm going to make, my first billion in the next 5 years. And so you're just there on your own. Yes, I've been trained. You're very good at what you do. You need a mentor. You need a mentor. Very important. You might need to find someone who is older, who has been there before. And it's a two-way thing. The mentee-mentor relationship is one that has been discussed at different fora. Very important to build resilience as a specialist. Take regular vacations. Please don't say, our money is not even taking us home. Where is the money to take a vacation? The vacation doesn't have to cost much. It might even be to your village. It might be to somewhere in your state, a resort. It might be a weekend getaway. The vacation doesn't have to be expensive, but take time off work, even from your private practice. If you need to get someone locum, please stand in for me. If you need to tell your patients I won't be available this period, don't be afraid by the time you come back, you will lose your market. You need a vacation sometimes. It has a way of recharging your batteries and building resilience. Sometimes in a vacation, you have the time to reflect on yourself because we get so busy that we don't have time to reflect. We leave early in the morning, we come back late, we land on our bed and we just sleep off if we are fortunate to be able to sleep. So sometimes it's important to take regular vacations. And whatever you do, please try to enjoy your work. Yes, you can enjoy your work. Don't believe that the locus to enjoy your work depends on your environment. There are also things you can do to enjoy your work. And sometimes if whatever you try in a certain location is not working, you might have the courage to move. Whatever you do, try to enjoy your work. Don't just endure it. In summary, we've discussed what the second victim phenomenon is. Don't say it's not my portion. It can happen to any of us. In fact, for certain procedures, adverse clinical events can happen, even with the best of hands. There are certain procedures that are very prone to that. And we've talked about the need to be there for each other in the form of psychological first aid. It's a helping approach that has been well-researched, strong evidence-based. And I've sent a book, a PDF from the WHO that can help. At the end of it, you can just snap only the last page, the Psychological First Aid Pocket Guide. And you might print out that page and post it somewhere in your office just to remind you and to learn more about psychological first aid. I would like to conclude this talk with a quote from Don Berwick, a very respected, healthcare expert, a pediatrician who specializes in improving health systems. He was once a chairman of some committees to address some of the issues raised by the Institute of Medicine report to Air is Human. He said, healthcare workers who get wrapped up in error and injury, as almost all someday will, get seriously hurt too. And if we're really healers, then we have a job of healing them too. That's part of the job. It's not an elective issue, it's an ethical issue. So I'm so happy that Nigerian Society of Anesthetists has chosen this topic for discussion. I hope it won't end here. It should also stimulate us to collaborate on research to see how can we bring this more to the consciousness of, the hospital administration, of government, and we can see how we can make the whole hospital health system a safer place, for both the patient and the healthcare worker. Once again, I will say thank you for listening, and I'm expecting your questions.
Thank you very much, Dr. Igwe, for that well enlightening and power-packed presentation. I will just summarize briefly what Dr. Igwe has said, and then we will go for the questions. So anybody that has questions should please indicate by raising the virtual hand. Then we'll read it and let him have his time. Of course, he took us through a very interesting topic, the second victim, and introduced the topic and talked about a very popular thing in anesthesia, that is the advanced clinical event, which is akin to our critical incidents or medication errors, as he put it. Of course, he has let us understand that nobody is above it, because to err is human, and the causes are not just anything but systemic. Now here he took us through preventing or he took us through the definition of these adverse clinical effects, and says that it is actually a preventable effect that can cause discomfort, or can be fatal, and it is not actually planned for. I went to the main meat of the story by talking about the second victim effect. Said that it is any effect that can affect a healthcare professional who is involved in the adverse clinical event. And we should not mistake it from vicarious trauma because they are two different things. Now, Dr. Egbe has let us understand that psychology always comes, or psychological first aid comes in when you have victims of this second effects. We as healthcare professionals, and he said support is very key. I know we have had several cases that has happened in the nearest or within the last few years, and support is key to solve this. Now, he has also taken us through navigating the second victim effects. Now, he has also told us about the basics of this effect. Of course, he said we have to be aware of it. Of course, when it happens, you have to be aware of it and be honest to yourself. He has asked us never to spend time alone or in frustration. We should also be introspective about it. Good introspection, as he put it. We should not isolate ourselves, and we should always try and communicate. He said we should avoid media interviews and get our own lawyers. Now, he told us about the recovery trajectory, the stages of the recovery trajectory, 1 to 6, and he has given us also the basics of this psychological event. Say the psychological first aid is better administered by a friend. So if you see somebody who is undergoing this event rather, if he's your friend, it's better for you to give that person this psychological first aid. And he told us about the 3 L's: look, listen, and link. Finally, he has asked all of us as professionals, as specialists, to try and build resilience. And we should try and know ourselves by using a matured coping mechanisms when we find ourselves in this situation. We should also try and enjoy our work and not just try to enjoy it. And whatever it is, we should always try and get a mentor. I hope I've done justice to this summary, and I will give all of us some time to try and ask our questions. Thank you. So I will read from the chat box as the questions come in. So is there anyone that has any questions, please? While the questions are coming in, I would like to acknowledge the presence of our teachers, our mentors, our professors who are present here. Although I can't fully see the list, but I'm sure that the president-elect will do justice to that very soon. Thank you. Okay, we don't have any questions. So maybe before anyone asks a question, maybe I would like to ask one, sir. In our practice as an anesthetist, we have these critical events that happens, and sometimes we have what's called a near miss. For example, as an anesthetist, probably you're doing a thyroid surgery where the face is covered and then the tube kinked without your knowing because it's a shared access, okay? Before you realize, even as keen as you are and as watchful as you are, realize that the patient is desaturating. You looked at your machine, you looked at your pressures, and you realize the pressures are going up. Before you could even look at the tube, the patient had gone into a cardiac arrest for a simple surgery he walked into the theater for. Probably you intervened immediately, did a cardiac arrest, gave bouts of adrenaline, and the patient came back and you'll be able to finish the surgery. So this is a psychological trauma. It makes you sometimes as residents, as physicians, doubt your ability to be observant, even though it is not your fault. And sometimes you just like, I will never probably take such a case again because I don't want to end. You didn't even enter a trouble. It was a near miss, but I don't even want to enter this kind of trouble. And probably because of fear, you have refused to tell anybody. So I don't know. Maybe you can navigate, especially the younger colleagues, how to go through this. So
Thank you so much for that question. Should I note it down? And because there's a hand up.
yes, I just noticed the hand, and
Okay.
please note my
So
question down. Prof
yes,
is
I
already
noted
raising her
down.
hand. Yes, so that Prof can ask her question. So I want to recognize Professor Uwanso. Please, ma, go ahead and unmute your mic, ma.
Okay, thank you so much. Thank you, the presenter, Dr. Egbe Otu. Thank you so much for the presentation. And thanks for the moderation, Dr. Rukewe. My question is, I joined a bit late and I didn't actually understand. I got in when you were talking about the psychological first aid after clinical events, but I didn't quite understand the second victim phenomenon. So I would like you to, if you can just go back a little bit on it to define it. What exactly does it mean to be a second victim phenomenon? Thank you.
Thank you, Prof. Dr. Egbe, you can attend to her question. Thank you.
Okay.
No, let me ask my own also before he attends.
Okay,
a few years ago, we were starting our new ICU, and I was heading the department. So I sent some of my nurses who were going to be manning the ICU to Kolebu Teaching Hospital. And when I was getting a feedback from them on the experience, because that was the whole reason they went there, so that they could, buy some good ideas which we could indigenize back here. One of the things I learned from them was that they were having periodic and very routine psychological reviews. As we all know, in the course of the presenter's talk, he told us some high-risk areas. He specifically mentioned A&E, theater, and ICU. And we work in all of these places. So you can imagine that we have a triple exposure to high-risk environments. So I am just wondering what you will recommend. Because as we speak, the NSA is that we are reviewing our standard guidelines for practice. So it would be good to know, is there any literature as per what is recommended? Is there any preventive, maybe resilience building, something preventive, rather than wait and come, after the adverse clinical events? Is it possible for us to prevent? And then also, in those high-risk areas where in a typical ICU, you're losing patients every other day or something like that, those kind of things. What will you recommend, or what do the books recommend in such circumstances?
Thank you very much, Prof. Ma, for the question. Probably before he takes all the answers, I think there's one more question on the chat box. It's a simple one by Dr. Udofia. It says, what if the psychological first aid fails, like in physical first aid? Thank you. So you can go ahead and address the questions while we wait for others.
Thank you so much for all the questions. So let me start with the second victim phenomenon. Usually when there's an adverse clinical event and someone suffers for what is thought to be avoidable, most people think it's only the patient that suffers, either disability, prolonged hospital stay, or death. So people are hurrying to, condole with the patient and the family, first victim. But the way doctors are trained, they want to help, they want to save lives. So they also suffer when a situation like that happens. And sometimes some doctors take it rather too hard on themselves, especially when there has to be an inquisition, they have to face a panel, media smears their name, and so many things happen. A lot of harm also comes to them because of these adverse clinical events, which they didn't intend. And so that is the concept of the second victim phenomenon. Not only the patient suffers, the doctor who made the mistake also suffers. And then people now talk about the third victim, the organization also suffers, or the HOD, the department suffers. Now, Dr. Rukeve talked about this thing that happens in thyroidectomy, and because of that near miss, the person is not too eager to take on such patients if they are on the list. That may be demonstrating some level of escape avoidance. It's an emotion-focused coping. Something happens to you. Some people, Africans will say, if you are bitten by a snake, you will be afraid of even a lizard. So things that scare us, we run away from them. But eventually, when you've introspected, you decide, okay, why is it important for this patient to have the surgery? The indications for the surgery, do the risk outweigh the benefits of the surgery? Of course, we will then discuss with the surgeon back and forth. But if it's clear that the benefits of the surgery outweigh the risk, yes, I'm taking certain risk, but I'm trained for it. How do I avoid this kind of situation? That's why I went through residency. I've gone through these procedures. I have to sign them for exam. That means I have experience in them. And I've seen other successful teachers handle this kind of situations. How do they handle it? So you're building up, you're being deliberate about your own skills now in those kind of risky situations. Because I must commend you, anesthetists. The way you hold this delicate balance between life and death. I hear sleep is a cousin to death, and you walk in that fear. So I really commend you people. But it's really important that you recognize you're trained for this. How do I get around this? How do I minimize this risk? That way you avoid this escape avoidance. Because how long will you keep running away from difficult situations or difficult cases? What are we experts meant to do? Professor Kalu, worked with us. We're trying to do an electroconvulsive therapy. For some reasons, we've not done it for some time in the center. I wanted to do the modified type where we needed to use anesthetic agents. We had done the pre-anesthetic review. We felt our equipment was in order. But there was one cord we did not connect to the right place. And we gave up to 2 sets of anesthetic medication, and we had not given the shock. I had to call other colleagues, other consultant psychiatrists who are experienced in the use of that machine. And we now discovered that the cord was not placed in the right place. Now, after that difficult experience, the next time I tried to do for the patient, the machine got bad. Will I run away? Will I say, no, I can't do electroconvulsive therapy, it's not for me? I was really embarrassed. Right now, I hear the machine has been fixed. I've walked myself through. That day was a bad day for me, but I've walked myself through it. And I'm looking forward, I was told the machine was fixed. I'm looking forward to doing that on the patient again. And hopefully this time, I will get better. We would avoid some of those mistakes. So the point is, we don't necessarily need to run away from difficult situations. If we notice ourselves avoiding taking up certain patients, and we notice it's related to our emotions, then maybe we need to walk ourselves through this and develop ways to minimize the risk or be able to work with such patients. You know, that's where we up our skills as experts in this business. I also want to talk about the programs, preventive programs or resilience building programs for adverse clinical events in departments of anesthesia, like Professor Kalu asked about. Yes, the literature, in fact, that's where the research is going now. What are the guidelines to put things in place? Because if you don't address the psychological sequelae of adverse clinical events, including near misses, people carry a certain burden. They are likely to practice defensive medicine. They are likely to be more anxious in certain situations, and that may reduce performance. That may even expose them to further mistakes. So, for instance, interpreted as a witch hunt,
Okay.
or an opportunity where people can be comfortable to talk about what they could have done better. That makes the healthcare safer eventually. That's just one example. There's a lot of literature, which I'm going to share with Professor Kalu. I'm going to share with Dr. Rukewe. And there's a lot. And I'm willing to collaborate with the Nigerian Society of Anesthetists. Let's look at some of those programs that can be put in place that have been tried in other countries. We can decide to contextualize in Nigeria and add it to the review we are trying to do. That's a very progressive thing to do. It will definitely make healthcare safer.
Moise?
Papa, am I sending this meeting? Alpha.
Psychological first aid fails.
Okay. Okay.
What if psychological first aid fails?
Nation.
That's a question.
They didn't bring another block.
You've gone there. 12 minutes.
Okay, I'm trying to
Oh,
help.
you like it, oh, no.
I don't know if the host, okay, yeah, she's been muted. So the last question is, what if psychological first aid fails? Remember, psychological first aid, yes, just like it has been compared to first aid in other parts of medicine. There's a traumatic incident, there's an unexpected event happen maybe at home. Ambulance personnel, paramedics come, or bystanders, they come, they are giving some aid while they are taking the person somewhere. Remember, the second victim phenomenon does not happen in every case of an adverse clinical situation. But every doctor who has gone through something like that deserves support. That's psychological first aid. Now, as you're being supportive to the person, as you're being around the person, as you're looking, you're listening, you will decide whether the person needs further assistance beyond just your being a friend in times of need. That's where link comes in. So just be there for the person. If all of what you're doing is not working, things are worsening, then you need to connect the person maybe to a mental health expert or tell the appropriate people to give more support. So yes, if it fails, just like the paramedics bystanders are giving first aid or basic life support while they are taking the person somewhere where the expert will now do the bigger things to save the life. The same thing in psychological first aid. Look, listen, and link when necessary. Thank you very much.
Thank you very much for addressing those questions. It's been a very interesting one. I don't know, there's no other question on the chat box. So we probably will have to introduce maybe I should call back Dr. Quinette. Professor Quinette to come back so that she can introduce the NSA president to address the House. Thank you very much.
Thank you very much, our able presenter. As our people will say, you know the forehand. You didn't forehand at all. Thank you very much, Dr. Egbe. It's always a pleasure listening to you. And then for those of you who joined early, Dr. Egbe is a consultant psychiatrist at the Federal Neuropsychiatric Hospital, Calabar. And he's available, as he has said, for research collaboration, and that is one of the best things I have heard today. Thank you very much. And thank you very much, Dr. Rukewe, for ably moderating this session. On this call, we have our faculty chairman of the West African College of Surgeons Faculty of Anesthesia, Professor Fola Fakonle. Thank you very much, madam, for joining. We have our past president of NSA, Professor Elizabeth Obolingwaso. Thank you very much, madam, for joining. We have Dr. Regina Onwudiwe, a very senior consultant. Thank you very much, madam, for joining. I think I saw Professor Odofia, consultant psychiatrist at Federal Neuropsychiatric Hospital, Calabar, and past registrar of the National Postgraduate Medical College, and my teacher. Thank you very much, sir, for joining. And so it is my pleasure. I haven't seen Dr. Obembe. I was expecting that she would be here to give us some information about the G4 Alliance. Dr. Obembe, if you're here, please, can you indicate? I haven't seen her. So it is my pleasure at this point to welcome our able president of the Nigerian Society of Anesthetists, Professor Alhassan Dati Muhammad, consultant anesthetist, Aminu Kano University Teaching Hospital. Welcome, President.
Thank you very much, our crown princess. As president-elect, you are the president in waiting, so there is no vacuum. And I want to thank you for all you do for Education Committee. I want to sincerely thank the speaker, and I apologize for joining very, very late. I couldn't help it because when I wanted to join, the computer was acting up, this time not network. So the topic is very apt. I had to read the topic over and over again. I said, but this thing is, maybe it's trying to talk about what we go through every day. If it doesn't happen to you, you are either, you may be investigating one case or the other, near misses and so on. I can tell you it's terrible. Like you said, I remember most of the incidents that happen. You keep thinking about psychologically and so on. I will listen to the recording because this is very important. Like the president-elect said, we are currently reviewing our standard guidelines. This is the 14th week. We are on it, and it will come out just to guide everybody. To minimize the incidences will still happen, but it should be minimized. And then when they happen, there shouldn't be, there are clear guidelines or documents that we can fall back on to improve the system. That is the most important thing. So, but this approach of psychological effect on this really is something that has to be addressed as part of our well-being. What is it I wanted to say? Then there is okay. There was a retreat I participated in, Smile Train, and we had the past president of West African College of Surgeons. This thing came up somehow because we are being quality, safety and quality for Smile Train. You know them, they are always on it and so on because of Sentinel events. So this thing came up, this psychological issue, and I raised it up. And I suggested to the chair, the past president, Peter Donko, and I said, look, why don't we it appears that we don't have, since they will be with us during training, after training, throughout your practice, they will always be there. If you're not involved, then you'll be involved in investigating one thing or the other. Then he suggested that I should write something. But you know what, it has to go through all these things and so on. But I just pointed out that I think we are missing that in our curriculum. We are not giving it the attention it desires. So a faculty chair is here. I think the fellows in the faculty, maybe we should take it up and push, because we suffer more than any other physician. Anesthesia, like you said, we work in the theater, we work in the ICU and acute areas. So please let us give this attention. Thank you very much.
Thank you very much, President. And on that note, we bring this webinar to an end. Thank you, everybody, for joining. Please encourage those who were not able to join the call live to listen to the recordings. The recording will be on our YouTube channel. Thank you very much, Professor Ehigiato Adayonfo. I hope I pronounced your name properly. Thank you very much.
You did very well. Thank you.
Thank you.
Enjoy the presentation. Thank you.
Thank you, everybody.
Thank you.
Thank you, ma. Thank you, everybody.